And thank you so much for everybody being here today. We are very excited that this is the final week of our newborn screening bootcamp. It has been a wonderful bootcamp, and we have thoroughly enjoyed the presentations and the panels, as well as the discussion groups. And I do want to make sure to specifically shout out again the team at Babies First Test of Expecting Health. They have been wonderful co-hosts of this event the past 2 years, and this year has been no different. They have been fantastic, and we love hosting this event with them. In addition, I want to thank our sponsors who make today possible and Bootcamp in general possible. So here is the agenda for our final day. So we will start off with a newborn screening policy update that I will give, that will talk about both the state and federal policy. In addition, we will have a panel about how conditions add to a state newborn screening panel. Perspectives from both the state newborn screening programs as well as patient advocates. And we're very excited about this panel to really bring together kind of all stakeholders involved in getting a condition added to a state panel. And very excited to give you an update about both the federal and state policy, kind of where we are and where we're going. Let me just get the animations up for this slide. Perfect. So first, where are we with the Newborn Screening Reauthorization Act? And so I would assume many, if not everyone on this call, is well aware of the Reauthorization Act, but in the coming slides, I'll go through some of the bill provisions that are very important. But I think it's always nice to start with the timeline of kind of where we've been. And so Congresswoman Roba Allard, Catherine Clark, Congressman Mike Simpson, and Congresswoman Jamie Herrera Butler introduced the Newborn Screening Saves Lives Act earlier this year. In addition, Senator Hassan and Senator Wicker introduced a Senate companion bill. And one of the main differences this year from last session was the fact that those two bills used the exact same language, which was a welcome sight. And then in June, it did pass the House of Representatives, which was fantastic. And so last session, it passed unanimously. This session, it passed by a 200-vote margin, but that, I would say, can be slightly misleading because it was passed under a suspension rule, which essentially means that it is passed as a collection of bills. And so there will be representatives who will vote against the package because of one of the other bills. So coming out of the House, we still have strong support with a vast majority of the House voting in favor, even under the suspension rules. In addition, the Senate Health Committee states that the reauthorization is a priority for them this year, which is always great to hear, but it doesn't mean that our work stops. We have to continue to let them know that we hear them when they say that, and we're going to hold them to that. Which is why during Rare Disease Week, we had more than 600 rare disease advocates participate in more than 350 HEAL meetings to advocate for the passage of the reauthorization of the Newborn Screening Saves Lives Act. So we want to continue to keep pressure on the Senate and I would say bipartisan pressure. We want to ensure the fact that everybody is hearing from us and we're talking to everybody and ensuring that the Senate is well aware that we need to pass this bill because the current status quo is not good enough. And so I'll go a little bit into detail of why that is. And so some of the key bill provisions, it does increase authorized funding levels for the below programs, which is always important. In addition, it reauthorizes HRSA grants to states to expand and improve the newborn screening programs to help educate parents and healthcare providers, as well as improve follow-up care for infants and detected conditions. I think this little sub-point right here is really important because it provides HRSA the new ability to award grants to address pilot studies, as well as to help to re-engage babies who did not receive the recommended follow-up appointments. And I think this is really important to note because it highlights the fact that the status quo is not good enough. And so we will talk a little bit about how there is still funding for the programs. And so you can get the question of, well, we still have funding, why do we need to pass this bill now? And the reason is because there are important parts of this bill that will improve the current newborn screening program. In addition, it would reauthorize the advisory committee and directs the committee to make the RUSP nomination more transparent. In addition, it reauthorizes the CDC to grants to ensure quality assurance for laboratories. And then this final part, it directs the National Academy of Medicine to conduct a study on how to modernize the newborn screening program. So that's a really important program, and I'll talk a little bit more later about why it's so important to look at how we can modernize the newborn screening program. And so the advisory committee was reopened as of March 20th, 2020, which is really important. It was authorized for 2 years, which is standard for a discretionary advisory committee. That authorization actually runs out in November of 2022. So hopefully we will pass the reauthorization long before that date. But if that has not happened, then we will have to ensure the fact that we can get this, the advisory committee, reauthorized as a discretionary committee. In addition, FY 2020, as I stated before, both CDC and HRSA programs did continue to receive their funding, which was great to see that the entire federal newborn screening program did not shut down because of the lack of the reauthorization. But again, as I stated, status quo is not good enough. So we want to continue to advocate for this bill. In addition, I want to close with kind of why we're stuck in the Senate a little bit. And so the Senate Health Committee has not yet held a markup of the bill, both last session or this session. This is because Senator Paul is pushing for a change to the bill that require parents to opt in to allow for the newborn screening unidentified blood spot to be used for research. And this would create a huge burden for the program. And it's important to note that, again, this informed consent is for the research purposes of the newborn screening process, not for the newborn screening itself. This is not about that. This is solely for research. And it's important to note that these are de-identified biospecimen. And so these biospecimen are used to help not only with quality assurance to make sure that the current newborn screening is working to the best of its ability, but also to ensure the fact that you can use these dried blood spots to help develop new diagnostic tools, new therapeutics to ensure that we can continue to grow newborn screening across the country. And so I think both of those are important to keep in mind when talking about this. And I forgot to say this at the beginning, but if you have any questions, please feel free to put them in the chat and I will be sure to answer them as we get there. And if you have any questions about the federal program, please do drop them in because we're going to move to the state work. But again, I am personally slightly optimistic that we can at some point get this done. That optimism is based on the fact that I know there's a lot of work to get done, but I know this community is there to get that work done. And so we have to continue putting the effort. We are continuing to meet with Senate members and their staff to let them know of the importance of this legislation and to ask for their co-sponsorship. And so we'll talk a little bit in a few slides about how you can get involved for both federal and state. But at the federal level, it's really encouraging your senators to support this bill as currently written. Perfect. So now for our state work. And so we are continuing to support RUSP alignment legislation. And so this really gets to the idea of once a condition is added to the RUSP, we want to ensure the fact that states can add this condition as quickly as possible. And so we're going to talk a lot about this today. But the elements of legislation are really threefold. So first, it would require the states to screen for any disorder recommended by the federal RUSP. In addition, it implements a timeline for when the state needs to begin screening for the new RUSP disorders. Currently, it can take on average 5 to 6 years for a condition to be added to a state program following its addition to the RUSP. And we generally believe that that is a little too long. And so we generally recommend for a 2 to 3 year timeline. But as you'll hear later today, adding conditions in that timeline requires a lot of work. And so to help support that work, we want to ensure that there's funding available moving forward to facilitate the addition of new screens and new conditions. Because we do not want to be in a situation where we are requiring the state labs to add this condition faster than they're ready because they do not have the proper resources. So we want to ensure that the resources are available to the labs to ensure the fact that they can add them in that timeline that we are requiring them to through legislation. And so in 2021, we did pursue this legislation in 4 states. In Arizona, Georgia, Ohio, and North Carolina. In Arizona, Georgia, and Ohio, these bills are all signed into law. And thank you to all the advocates who participated in that because we could not have done it without your help. In addition, we are currently awaiting passage for this legislation to be passed in North Carolina. So we are hopeful that we can get this done in North Carolina as well. And also want to highlight that we will continue to pursue RUSP alignment in 2022. We are not done. We're going to continue this effort. We are in the process of deciding which states we're going into. And so we will continue those efforts. I'm just going to take a pause here because I see a question is in here about the federal work. I want to make sure I address that before we move to the next stage. Will Rand Paul get his way? I think that's tough to say. I think the short answer is we hope not. I think the patient advocacy community as a whole is speaking out in one voice against this. And so that is a strong voice. And we have champions on the Hill, both in the House and in the Senate, and we have bipartisan champions on both those. And so we are continuing to work hard to get this done without the amendment. But we are recognizing that this is going to take some time. And so it hasn't already been taking time. To get that all done. And so we will continue to work and we will continue to work to ensure that this amendment is not included. And we believe that it's definitely possible for that to be done. I did see a question also in the chat about how do we decide which states to go into. And so that is a variety of criteria that we look at. One will include birth rate, how many conditions does the state currently screen for, diversity within the state, advocates within the state. In addition, what is the legislative session? And so there are a wide variety of conditions, criteria that we look at. And so we're kind of in that process of coming to final decisions on that. My apologies. There we go. And so going back to what I talked about before, here's how you can stay up to date at the new Every Life Foundation Newborn Screening Action Center. And so this is a great place to really learn about any updates that are occurring within both the state and federal policy that I've been talking about today. And you can come in and learn more about newborn screening as a whole. You can use the action alerts that we have posted on our Action Center to get in contact with your senators to let them know about the importance of passing this legislation. And so it's a great place to go to join and to really learn about newborn screening occurring across the country. And as you can see there, you can find it at rarescreen.org. And the last thing I want to briefly talk about is the newborn screening monitoring study. And so we're really excited to partner with other rare disease leaders and that's collaboration on how to modernize newborn screening. And so this will partner with what we hope will be, which will eventually be the National Academy Moderation Study. And the reason that both of these are needed is because newborn screening for the past 10 years has widely been regarded as one of the most successful public health programs in the country. But we're also well aware that there is going to be an influx of conditions trying to be included in state newborn screening panels. So we want to evaluate the capacity of newborn screening in the United States to all newborns who may benefit from new treatments and to provide policy recommendations to ensure the equitable access to newborn screening. So how can we ensure the fact that a public health program that has been so successful in previous years continues to be successful moving forward as the influx of conditions with genetic testing, with genetic therapeutics available will lead to the increase of newborn screening. And we are excited to announce that we will be able to speak about this at our Rare Disease Congressional Caucus briefing. This is open to anybody, to the general public, and it is a newborn screening modernization, ensuring success in the 21st century. And so we will be able to talk about some of the early findings from that study, and we're very excited for that briefing. So it is Monday, October 25th at 2 p.m. The registration, you can drop it in the chat box for this event because it has just gone live. So I really do hope to see everybody there because we are very excited for the caucus briefing later this month. And with that, I believe I was actually able to get to most of the questions throughout during. So because we have such a full schedule today, I do want to move on to our panel for the day. And I want to pass it over to our moderator for the day, Natasha Bonhomme, who can introduce our wonderful panel. And thank you everybody for being here today.
Hi, Dylan and everyone. Thank you so much for that great update. I think it's a perfect segue into our session today, where we will be talking about how a condition is added to a state newborn screening panel and everything that comes from that. We have a great panel today, so I will be doing a little bit of a reading because this is a very impressive group and I don't want to forget anything. But first we have Dr. Susan Tanksley, who is the Laboratory Operations Manager in the Laboratory Services section of the Texas Department of State Health Services in Austin, Texas. She manages the day-to-day operations of the Texas Public Health Laboratory, which encompasses the state newborn screening, clinical chemistry, microbiology, environmental chemistry, and emergency preparedness laboratories. These high volume testing areas process 4,500 to 5,000 specimens per day. Dr. Tanksley's focus has been on newborn screening program expansion and improvement, including implementation of evidence-based performance measures in the pre-analytical and post-analytical phases of screening. We also have Kristen Vonix. After her son was born with PKU, Kristen co-founded Georgia PKU Connect and became a leading advocate for medical foods coverage. She is a trusted expert on medical nutrition legislation and has led advocacy initiatives at the state and federal level for more than 10 years. Kristen serves on the Georgia Newborn Screening Advisory Committee and the National PKU Alliance Affiliate Council. She previously chaired the Southeast Newborn Screening and Genetics Collaborative Consumer Alliance, which is part of the national effort around genetic services, and serves on the board of the Southeast Regional Genetics Group and the National PKU Alliance. We also have Tara Britt, who may be joining us a little bit later, who currently serves as Associate Chair of the North Carolina Rare Disease Advisory Council and Network. The council was created as a result of co-authoring legislation with North Carolina patient advocates to create a rare disease advisory council, and then signed into law in 2015. Tara is also the president and founder of Rare Disease Innovation Institute, which is a global nonprofit focused on educating, engaging, and equipping the rare disease community to achieve higher quality of life, accelerating diagnosis, and enabling access and treatment. And so while we typically don't read all of this, I think it's really helpful to get a sense of what everyone works on and just the wealth of information that is presented here with our panelists. So thank you so much to all of you for joining. I am going to start off with a question for Susan. As someone who has onboarded multiple conditions and you work in one of the largest newborn screening programs in the country, what do you see as both the major challenges as well as, what excites you, what keeps you in this when thinking about expanding newborn screening?
Thanks, Natasha. So I'm going to speak from a general perspective, and then I'll just try to sprinkle in Texas and the things that we do specifically. But in general, the very first thing, and Dylan kind of talked about this in his opening with the initiative to bring states in alignment with the RUS, is the authority to screen, and who makes that decision for the state. And our statute actually does require us to screen for conditions as funding allows that are on the RUS, but it also gives ability for newborn screening for our newborn screening advisory committee to make recommendations of disorders that are not yet on the RUS as well. Funding is a huge issue, and I know that that was mentioned in the RUS alignment bills as well. The ability, it really does no good to have authority to screen if there's no funding to make that happen. And I'm going to note it as resources, but really to have staff, to have capable, qualified staff who are able to not only bring a new disorder on, that requires a little bit higher level, and it's not just the science behind it, but the logistics behind it and technical capabilities, but the ability to sustain that and not just for the testing, but you have to have that for the follow-up as well. And just within the newborn screening program, that's important. But I like to remind everyone that newborn screening is a system, and it's not just a test. And not only is it not just a test, it's not just the program, but you have to have the ability you have to have the capacity within the healthcare system to handle the results that are going to come out, and you know, to be able to do the diagnostic testing wherever that's available, and the ability to have the children be able to have those tests done. So whether that's insurance, Medicaid, or some other mechanism to get the diagnostic testing done. And then of course there's what you do after you have a diagnosis, and that's, you know, that the screening is just a tiny portion of the time in that child's life. And after there's a diagnosis, it's you know, how is that child treated, and how do we ensure that they're getting the proper treatment, and you know, just the ongoing care, the continuity of care. And as they, you know, grow into an adult, then how do they transition and have the proper care as an adult as well? So the other things, just as far as implementation are concerned, that are really important considerations of newborn screening programs. So we have to have the space, the infrastructure to actually bring on a new condition, and that's something that has a huge factor for us as we consider timing of adding disorders. And then in addition to that, competing activities. So every time we add a disorder, it is competing with something else we're trying to do in our program. We don't just screen every day. We do things to try to improve our program as well, and to move us forward. And we can't just move forward with the new things we're doing. We have to try to move everything forward. And so those are all considerations as we, I guess, time the implementation of disorders.
Great. Thank you, Susan. One thing I wanted to follow up is, you know, you mentioned screening for conditions that are not yet on the RUS. Can you talk a little bit about that from, you know, your perspective and running the Texas lab?
We haven't. So when the advisory committee was set up several years ago at this point, that was authority that was given to them in statute, and is not something we've exercised yet, but we have recently established a rare disease subcommittee of our advisory committee. And so we are just now beginning to explore how that might be done. You know, what are all the things that we're required to examine prior to making a recommendation that the state add something new.
Great, thank you. My next question is for Kristen. You know, PKU was the first newborn screening condition that was screened for, and we have over, you know, essentially over 50 years of data around how that's been going. Why do you think it's important for you and, you know, the PKU community to still be really involved in newborn screening when there is obviously a lot of attention about adding conditions, but obviously there's still work to be doing in the space that you are. So if you could just speak to that and how you see those pieces connected.
Sure. I think there are several reasons why I think PKU advocates are drawn to be involved in newborn screening work, and also feel that it's important for them to be there. One, I would say, is that as a PKU parent myself, I really see and I've experienced the benefit of newborn screening, right? It's changed the course of my son's life. And I think we hear about the other conditions, whether they're on the panel now or maybe future conditions when we're out learning about, you know, just newborn screening in general and meeting other advocates. And you sort of have a sense of, you know, I want to help because I can see the benefit that our community has had. And so I think advocates want to understand what is happening with the other disorders so that they can be helpful, because, you know, even though newborn screening has been an incredible success, you know, the PKU community, you know, has faced challenges, right? So especially in terms of treatment access. So as Dr. Tansley had said, it's not just a test or it's not just a screening, that the real success is making sure that every baby that's screen positive has all the resources that they need to really be healthy and successful in life. So I think serving, say, on a newborn screening advisory committee we as PKU advocates can bring that perspective to the table, as conditions are, considered, and say, okay, if it makes sense to add this condition, if there's a test, right, a screening test that works for it, we have an effective treatment. Okay, what are the questions that we need to make sure we're asking at the state level or at the federal level? If you're, a PKU advocate working at the federal level, do we have clinicians that treat these conditions? Are the treatments accessible? Are they affordable? Do the laboratories have the funding that they need to implement the conditions? I mean, that's really important, right? Do they have the people and the equipment and all of that? So I think as PKU advocates, we've experienced a lot of this, every day. And so to the extent that we can be helpful in making sure that it works well for not only the PKU community, but other disorder groups, and I think we're happy to do that. The other thing is, Dr. Tansley touched on this, is that, as new conditions are added to the RUSP, it does put a lot of strain on the system. So right in the newborn screening labs, you need to make sure that you have what you need from a funding perspective to do those screenings. But you also have, limited sort of, geneticists, clinicians out there. I mean, that's a big issue that I think the newborn screening community is facing. And as you bring on more conditions, that's more patients that are flowing into the clinic. So do they have enough doctors? Do they have enough dietitians, genetics counselors, psychologists, social workers to really, really care for these patients in the way that they deserve to be cared for? So I think also, it helps, it's important for the PKU community and any disorder that is currently on the panel, any advocates that are associated with those, is that, we bringing us or participating in making sure that the system continues to work effectively as we add conditions is really, really important. And as we don't want it to just continue on, there's things that we can do better as well, right? Collect long-term data, how are these patients doing? Because I think that's something that, although we have a lot of data, we don't have a lot on long-term follow-up. So there's just a lot of opportunities. But I think the bottom line, at least for me, is that I feel that just incredibly grateful, right, for newborn screening, and to the extent that I can give back and be helpful to other advocates, then that, and I see that in other parents and other adults with PKU and why they want to get involved.
Great, thank you so much, Kristen.
Sure.
And I definitely echo that. Newborn screening is an amazing system, and there's so much great work that happens. And there's a lot of opportunity to build upon that if we have all of the right resources and attention to that, as Susan mentioned. My next question is for Tara. Especially with the work that you do both at the state level and also really looking at, how to engage and equip the rare disease community. When we're thinking about newborn screening, there's a lot of focus on the screening and getting the testing right. And that makes sense, because if you don't have a good test, you're not going to have newborn screening. I think thinking about that, but also thinking about newborn screening as a broader system, from your point of view, what else or what should stakeholders be focusing on when it comes to newborn screening to make sure that it is working at a systems level?
That's an interesting question. So do you mind if I say a little bit about what we're doing in North Carolina, just as, I'm trying to use this as an example for education and policy. So, 3.5 years ago, we added 3 new indications: MPS, ALD, Pompe, and then SMA was added. And SMA they're already testing for. But during COVID, it really set the state lab back. We had an unusual situation in North Carolina where we had almost everybody in the state lab left because, COVID was hitting. They weren't, they're not paying people enough that are in these labs. I've learned that's a really significant problem we have, not just in North Carolina, but other state labs as well. And so it was very important that the days that we're going by focused on COVID, and we knew that was important, were days that were not focused on newborn screening. And adding these indications, we thought, oh, well, you know, certainly within 2.5 years, certainly, and there's been media about it. We've had so much, but it's been, I think, in our community, it takes, you know, you have to work with that state lab. I mean, they're doing, you know, they're doing the important work, and it takes, I try to assemble through my nonprofit Rare Disease Innovations Institute, and we're addressing issues with the state lab like we have been with these indications still not being tested for. We usually have a call every month or two, and I'll assemble a group of people to say, look, you have to be transparent. What's going on with this? You know, the money's there. What is going on? You know, step by step. I think, and not seeing us as adversarial, but letting them know that every day that goes by, you know, there's going to be a rare disease that we didn't catch. And, you know, it's like my friend Terry Klein with the MPS Foundation said, look, people are traveling all over the world because North Carolina is home to many of these centers of excellence in rare disease. We're treating people all over the United States, but yet we're not treating our own because of newborn screening. And that was very impactful. But honestly, I'm looking at this as I'm going into other states to help states develop councils as well. We are looking at newborn screening legislation at the very same time we're looking at developing these councils, because I think it is so important. Somebody asked me not long ago, well, Tara, if you had a choice between developing a rare disease advisory council legislation or putting in newborn screening legislation, what would it be? I said, well, that's a no-brainer. Newborn screening saves lives. That's the bottom line. It saves lives. And so now I think it's so important as we're developing councils or either implementing councils that we're addressing the newborn screening of that state during the time that we're doing this. During that time, I think it's so critical, so that when that council kicks off, that is one of the first things we look at, that and access, of course. But newborn screening, like I said, we've developed a great relationship with our state lab. And even though now we are testing with SMA, we still have those 3 we're hoping end of the year. The state lab director called me a week ago Monday. He said, I want to give you a report. Here is what's going on. And then after that, you can bring whoever you want to the table. We can go over the whole Gantt chart we've got. And I want to show you how transparent this all is. And I said, what can we do for you? What is it? And this is a little bit different. What can us, as the patient advocacy world, in my world in policy and education, what is it that we can do for you to help the state lab get these things accomplished in a much quicker fashion? Because now this year, Every Life Foundation, we work with Every Life Foundation. They introduced legislation to put a time limit on any new rare disease being added to the state newborn screening panel. I think that is important. I think that needs to be going into every single piece of legislation that we honestly put forth from this point on in every state. There has to be a time limit associated with that. I think it's very, very key. I wish we had done that years before, but you know, we're doing this now, and I think that looks good. But I think, you know, time is of the essence with newborn screening, and I can't reiterate that enough. So if we can, so for example, this last conversation I had with the state lab director, I actually then had a talk right after that on that Monday with the director of public health for North Carolina. I said, what can we do? What can the advocacy community do? What can I do in the policy community and education to help you get these indications tested for most efficiently and quickly? And I said, can we fight for you on the behalf of salaries for these people? And they said, yes, we may need you all to come in and talk to the people in the state about how critical these positions are, and they should be funded appropriately. Because currently right now in a lot of the state labs, not just in North Carolina, they can't get people because people are getting paid way more to go work at a LabCorp or a private lab funding or a hospital system part-time. So I think that's one of the things. I think we've got to look at this in a holistic way with newborn screening. All of us want, the advocacy world, education and policy. We all know this is important and time is of the essence. But I think what we're trying to do is understand the whole picture and understanding what the state lab is having to go through versus, you have to make an assessment. Are they just putting this on the back burner, or is there truly hurdles that are being passed? And with adding equipment, there has to be training, education with any new piece of equipment added to test any new indication. So I think we're approaching this a little bit differently now in North Carolina, where I'm saying, what can we do to help you help us? And I think it's changed a lot of, instead of calling in fear now for, oh my gosh, there's Tara Britt calling about why we haven't tested for these diseases yet. It's like, what can we do to help you make this happen so that we are testing and we're catching these early on?
Great. Thank you so much, Tara. I think that's such a critical piece in terms of having those lines of communication really be open and hear all the components that go into adding a condition or adding multiple conditions. And we all have our roles to play, of course, and that doesn't mean we're going to agree on every single nitty-gritty detail, but we all are also on the same team, right? And that's a team to have the best care and early detection for these kids, and to do that in the best way, and in newborn screening from that public health perspective. I am going to actually build off a question because you brought this up, Tara, to Susan. Tara mentioned a little something called COVID and what that means and the impact that that can have on a newborn screening program. And I was just wondering if you could speak to that, both COVID, but I know you've also seen, and we were talking a little bit in the waiting room about many of the different public health emergencies that you have seen and had to guide the whole lab around that, not just newborn screening, but everything through that. And if you could just speak to that and anything you wanted to add on that topic.
Sure. Thank you. Thanks so much for the opportunity. And COVID early on, so March 2020 feels like forever ago, and yesterday at the same time. In about mid-March, I was pulled into a room at noon to be told that at like 1 o'clock, the agency was going to announce that it's closing, and anybody who's non-essential needed to basically pick their things up and go home. And the laboratory was considered essential, but we had to scramble and try to figure out, how do we continue to work, and how do we do it safely? How do we protect our staff? And we worked to quickly adopt any safety mechanism we could, and from stretching our staff the days out so that there are fewer people in proximity of each other, and even having lab staff telework, which just would have blown our mind pre-COVID as to how do you have staff who do bench work, telework, and so we had to put a lot of things on hold immediately and say, okay, we're going to have to stop our work towards implementing SMA. We are going to have to stop our work in trying to switch out our liquid handlers that are used for SCID and SMA. We're going to have to stop our work on trying to switch our technologies for screening for the endocrine disorders. We had to put a lot of things on hold in order to figure out how we were going to get the daily screening done safely. And so we did a lot of things for, it seemed like forever, but literally for about 2 months before we said, okay, now we have to figure out how we're going to continue with all of those things, and start picking up the pieces and bringing in, like a requirement for staff to wear masks, and trying to bring in plexiglass to do where we couldn't social distance, and introducing unidirectional workflow in places where we'd never considered it before, and stretching, moving computers, just, anything we could do so that we could have more staff in the lab doing work at the same time, trying to resume normalcy, which it's not normal at all still. But then we started figuring out, okay, how do we begin to pick up the pieces and move towards all of those projects that we had started but stopped. And it's had a huge impact, and I appreciate so much of what Tara mentioned about working with the North Carolina lab and learning about their issues that they're facing, because lab staff are in high demand, and anyone who had any molecular skills at all, their price tag went up a lot. And we've had a lot of people turn us down. We've had initiatives to raise our salaries in the state, and we gave significant raises, and yet we're still nowhere close to what the market is right now for those staff. And so it's been a struggle, and we continue to move on, but we have lots and lots of vacancies, and you know, we lose qualified staff, and losing qualified staff is a really hard thing to do. It's hard to make up for that time. You lose a qualified person, and even if you brought someone in that had a high educational level, if you can afford the person that has the experience and has the high educational level and the ability to kind of pick up, there's still this huge training time frame that you're going to have to do regardless of what they've done in the past, because newborn screening is so specialized. And most people don't come in with a newborn screening background. We grow them in our lab. And then we're usually a training ground for a biotech company or another lab at this point. And so, you know, those really have been the challenges. We have really persevered over the last year and a half, and you know, are super thankful for the staff who have stuck around. We're very appreciative anytime we make an offer and staff, you know, they accept it and they come in and they do the training and, you know, become part of the team. It's a lot of work, and it's really sad to see those people go. I am happy to report that we are fully functional now and figuring out how to work. And we've had one case that we know of transmission of COVID between staff in our entire laboratory. That doesn't focus just newborn screening, but we have like about 250 people in the lab daily on site for all the testing that we do in our state lab. But we figured out how to keep people safe for the most part, and so we are continuing to move on and make strides. And I think our biggest hurdle right now is the ability to attract staff and to retain them once we have them.
Great. Thank you. Thank you for sharing that. And as has already been mentioned, you know, if we're looking at adding conditions and again, not just adding a test, but then making sure that, you know, all the systems parts are there, that takes people, and that takes skill and talent and time. So really helpful to have you kind of lay all of that out. One question that came in through the chat is for Kristen, and really asking, you know, when you were speaking about the work on the advisory boards, I believe this is state-based advisory boards, you know, are all diseases that are screened for represented? And if so, in what way?
So I would say there are not patient advocates representing every single condition. So like, for example, like I'm a PKU advocate, but I try my very best because we don't have somebody, you know, other advocates with other inherited metabolic disorders. I do try to make sure that I keep my eyes and ears open and advocate for them when I can. Sickle cell is very well represented in Georgia. PKU, we have people that we do try to create a balance, right? So we can have up to 21 people in Georgia on our advisory committee, and we currently have 21. So we do try to max, you know, it out the best we can so that everybody is represented. Now, there are a lot of clinicians on the advisory committee, and so they can really speak to a lot of the different conditions, which I think is really important. We also have subcommittees we aspire to have subcommittees that are very active for each of the condition groups. And so I think we're missing one or two right now, but we are trying to bring them back because some of them, COVID impacted, right? People getting together and people's time. And so that's something we're trying to do. But we do make sure that we, you know, perform oversight on all the conditions and look at, you know, who's screening positive, is there follow-up? So we do try our very, very best to have representation in some shape or form. I will say for if, for example, there isn't somebody representing a condition, like say, hearing loss, there's people that aren't voting members that come to all of the committee meetings. So we have a very long list of people that always attend our twice-a-year meetings to make sure that, if they want to give public comment, or maybe we need to call them as an expert, because we do create work groups that aren't just made up of a voting member. We bring in experts, whether, we benefit in Atlanta for having the CDC. So it might be somebody from CDC, it might be somebody from the state lab, Emory, the Children's Hospital. So we do try to make sure that we have good representation. It's important. It's a really important thing that we need to make sure we aspire to all the time.
Great, thank you, Kristen.
Sure.
I mean, that is something that at Babies First Test and Expecting Health, we often really push for our different partners to think, sometimes you may think, oh, we need all of these different clinicians and clinical voices, which is true. And then they're like, oh, and we need a parent perspective. And there is no such thing as one parent perspective or one family perspective. Everyone goes through different experiences, whether that's based off of the condition that is in your, that is detected, that you're diagnosed with or not diagnosed with, or the healthcare system that you're coming from, or a number of different things. So I'm really thinking about how do we incorporate multiple family and patient perspectives is really important, and for people to share their experiences with each other, right? So then whenever anyone does have that opportunity, you can say, well, my experience was this, but I also know my friend or someone that I work with, their experience is that, so that we have those opportunities to bring that to the forefront. My next question really is to everyone on the panel. When we've talked a little bit about this, but what role does data collection and reporting play in the work that you do? Is there data that you wish you had access to or that you need to achieve your goals? And we all wear multiple hats and there are many different goals, but I think particularly focusing on when thinking about a new condition being added to newborn screening. Susan, I know that you wear lots of different hats, one of which is being an organizational liaison or organizational member for the Advisory Committee on Heritable Disorders in Newborns and Children. And so sometimes you're looking at information about conditions that have recently been nominated. So, looking from that perspective, Kristen, we already talked, there's 50 years of newborn screening for PKU, not necessarily 50 years of in-depth data. And Tara, in terms of the state work that you're doing, what's the data that you come across and what do you wish you had? We can start things off with Susan.
All right, thanks. So, just thinking about it, first of all, just from a screening perspective, and even if you think about new disorders that have been or being considered for addition to the recommended uniform screening panel, we really have to have good data to tell us, what is the incidence of the condition? What do we expect from a screening test? Are we going to expect to have, or is it a good screening test? Are there a lot of false positives? Are there false negatives? Things like that, just from a screening perspective and lab, you think about that. But when I think about what would I really like to have from a screening perspective, and I think probably everyone would want most of these things. We really need the long-term follow-up data. From the lab, even when we screen a baby and they're positive, we'd really like good diagnostic data to know, what is the true diagnosis? And you're not going to have that all the time in the beginning, and it may take some time to establish the correct diagnosis, because that may change over time. And does the diagnosis change over time? And, we need to know that as well. But is the condition being treated? Is the child just being followed? Are they under actual treatment? did us picking them up in newborn screening make a difference? Would they have been exactly the same if they hadn't been identified? And why is that important? Well, that's important because if we call them out as a case, or sorry, if we call that result out as an abnormal, as out of range, and there's diagnostic testing that has to happen, and there's, you know, all this follow-up, maybe even for years, that has to be done, but there are never symptoms. Have we done more harm to the system? Have we overloaded the system with no benefit to the patient, to the family? Are there things that we are picking up that really shouldn't be picked up through newborn screening? Is there a different time that they could have been picked up? Could they have been diagnosed clinically without harm to the child? From a screening perspective, and we have discussions within our own program as to, you know, it's like we're looking at false positives, and are there unnecessary false positives, and how do we make it a better screen so that it's not overwhelming to the healthcare system, but we still want it to be a benefit to the child. And I know from some of the discussions we have even within our own program, they'll say, but it's important because that child's on treatment. But is the treatment effective? I just really think there's so much information that we don't have, or we don't have aggregated to be able to make real conclusions about how effective the screening that we're doing now is in the long term.
Mm-hmm. Thank you. Tara, do you want to chime in?
I think what Susan said was actually really important. Like, you know, it's like an evaluation method that you're doing with this. I think data, I mean, one of our top pillars in my nonprofit is about data, because, you know, it's hard to convince people when you're trying to have legislation come through. It's very hard to convince people of stuff. You can see the most obvious, like you're going to, you know, improve a quality of life, you're going to save a life. But what about the, you know, what some legislators want to see? What about the economic impact to the state? You've got to have data with this. I mean, we talk about this almost on a daily basis. We talk about it weekly for sure with different groups of folks, like how key data is. And so, for example, you know, when I first started working with newborn screening many years ago, I've got this this one page. I think most of the advocates have something similar to this with whatever disease. And I was giving a talk actually. I was working with IBM Watson on some rare disease projects, and I was in Tokyo giving a talk about, and newborn screening was one. It was a part of the talk I was given to with rare disease, and I put a picture up of two kids that both had been diagnosed with ALD. One was diagnosed with newborn screening, and he's on the soccer field playing and living a normal life. And the other child is a vegetable in a wheelchair because he did not get picked up with newborn screening. What about the data surrounding that? The cost of caring for a child, the impact on the family, the impact to the state, because a lot of legislators, they want to hear what is the impact of that state, the social impact of the state, the economic impact of that state of if you're not caught with newborn screening, where you could go on to live a good life and your family could live a better life. So, but if you're not caught, a parent sometimes, if you've got a child with a disease, can't work. I was just on a call earlier this week when we had our North Carolina Rare Disease Advisory Council call, and a parent spoke. He was an SMA parent and spoke on behalf of these things. And it's data is so needed, not just the economic impact, but data to follow some of these cases all together, like what Susan was talking about. It's a lot to kind of grasp. It's more than just one type of data about, you know, the better quality of life or the economic impact. It goes into, well, like she said, are you running tests that you're not? It's to me, that's more of a, you've got to look at this and evaluate it in a proper way. And you know, currently it's a rush because everybody is in, all of us feel this way, urgency. You know, I tell people one of the reasons I got into rare disease, I was working in gene therapy, And I had an email from this man in India one day, and our lab in gene therapy specialized in Duchenne muscular dystrophy. And his son had just been diagnosed with Duchenne. And he wanted to know what kind of clinical trials were going on. And so I deferred to my boss, and we wrote something up. We sent it back to him, and he responded in 2 words, which I think really sums it up for the rare disease community with newborn screening and everything with that. His 2 words were, "Please hurry." And I think we're very focused on, please hurry, let's get these newborn screenings. We are going to have to look and evaluate, and we're going to have to, data will be key for sure. Data is always, a primary issue, but I think there will have to be, data coming through at the state and at the federal levels.
Great, thank you. And Kristen, your comments on that?
Sure. I absolutely agree. I mean, long-term follow-up data is really important, right? In the PKU community, we've seen a lot of those babies are lost to care as they age, right? As they transition to adulthood. Biggest issue, one of the biggest or the biggest issue is the access to the treatment, right? Not being covered by insurance, and it's very expensive. It's also a difficult treatment. So you need, to make sure that you have support around you and a support network. So I think the long-term data is just critical, and the more we can do for that, the better. And just to give you an example of a specific piece of data that I wish that we had, is that probably 10 years ago, when I was working to try to do something about filling the gap in coverage for medical nutrition here in Georgia, is that we had a pretty big issue with access for adults. We still do, but it's much better. And I was hearing that we were having a lot of maternal PKU syndrome babies being born in the state because we had a significant number of women, right, aging out of Medicaid. And once that happened at their 22nd birthday, they no longer had their medical formula. And so they were seeing quite a number of babies, in the clinic, right? The moms would call the clinic, and the clinic would try to help and do everything they can. But what I really wanted in order to help advocate for making sure that this treatment was accessible and we could put a stop to this situation was, I wanted to know, okay, how many babies are being born in Georgia or in the United States with maternal PKU syndrome? And that's something that is not tracked nationally. So, if you have a baby born with one of the birth defects that comes along with maternal PKU syndrome, that's tracked, right? That's probably tracked as a birth defect at birth, but it's not tied back to the fact that, the mom had PKU. And I think if we had that type of data, it would be incredibly powerful when we try to influence, policy changes. If I could bring down to the legislature and say, this number of babies have been born with maternal PKU syndrome over the last, 25 years in the state of Georgia, and one of the primary reasons is they don't have access to treatment, or they need, social workers. They need more psychological support to make sure they're staying on their treatment. They need better transition to adulthood. Then that would have been very powerful. So that's just one example, but there are so many, and I think the more we can do, I know people are working on it. We're trying, and as some of you have mentioned, funding is the biggest issue we have. Funding in the labs, funding in the clinics, funding for research, right? And so I guess the more we can do as advocates to really, bring attention to these needs, the better.
Great, thank you. Thank you for all those responses. And yes, data is so important at all stages, right? They're at every step of the way, even preliminarily when you're just looking at a condition and thinking, okay, will this actually work in a newborn screening system? Being able to capture that data. And we know that there are so many silos too. So even though we, from the work we do, we may see a family who gets services through, MCH funding from, starting at the federal level and into the state level, and then also needing support from a rare disease perspective. But at the agency level, rare disease is here, sometimes even genetics that's yet not considered rare diseases over here, birth defects and birth and the registries that go along with that is over here, when we know we're talking about all the same families. So if there's a way to be able to pull that data together and share it back with the entire system, that definitely would lead to, I think, alleviate some of the issues that we've just been talking about. Another question that I want to ask that may not seem to fit, but I think is important for us to really be considering is, we talked about the impact that COVID had on, adding conditions and on a newborn screening program. There are a number of things that can, for lack of a better word, threaten a newborn screening program and progress in newborn screening. And one of which that has been around for a number of years and maybe kind of making a comeback are issues of state lawsuits. There have been lawsuits in different states around privacy issues, property ownership issues, a range of different things. This is something that unfortunately Susan has had, I would say, more than her fair share of dealing with. But, for all of our panelists, that not only are these lawsuits and issues of consent also is another one, a threat to the expansion of newborn screening, but really it's sustainability, and both from a time and resource perspective, but also the potential outcomes. And so I just wanted to hear from all of you kind of what thoughts you've given to this and, what you think different stakeholders should be working on and focusing on around these issues when they come to a level of a lawsuit, which really is saying the state is doing something wrong, something fundamental in how newborn screening is done and what we've all invested in is wrong or an affront. I will start with the person that I know has a lot of experience with this. I'll start with you, Susan, on that.
All right, thanks again. And just to give everybody a little bit of background in case you didn't live through this daily like I did. So Texas was sued twice pertaining to the use of residual dry blood spots for newborn screening. So in March of 2009, a lawsuit was filed against us, and literally, I think Minnesota's lawsuit was filed the day before ours was filed. They were day after day. Who was first doesn't really matter, because it was painful for everyone involved. So our lawsuit alleged that we had violated the U.S. Constitution, Fourth Amendment violation in regards to unlawful search and seizure, and 14th Amendment violation, alleged violations of the rights to liberty and privacy. At the same time that this lawsuit was going through, we had requested changes to our statute to actually allow us to utilize blood spots for quality assurance, quality control purposes, as well as for research. And we had worked prior to session starting to kind of lay out what were the things we wanted to preserve. And we kind of had an inkling that something might be coming, because we had an open records request from a local newspaper about this, and probably 6 months before the story hit, they had been asking questions. And so we had laid out, what were the things that we really wanted to be able to preserve. And we did think that research, and we still think research, the ability to do research is important. And so the lawsuit itself, the first one was filed in March of 2009. We actually settled that lawsuit in December of 2009. And between that time frame, we did have statute changed, and it did allow for those uses that we wanted to be put into statute. But because of when the lawsuit occurred, and it occurred during legislative session, we also were required, we had language that was inserted into the law that we wanted implemented, that required us to disclose to parents that the specimens would be retained and give them the opportunity to request that their specimens be destroyed. And so that was put into law, and we had to immediately implement that. So in December, we settled the lawsuit, but as a consequence of that, we had to destroy any specimen we had received prior to May 27th of 2009, which is when the law went into effect, unless we had written consent to retain it. So what that resulted in was the destruction of approximately 5.4 million specimens. We also had to do some other things that really are about being transparent, and transparency is incredibly important. And we do everything we can in our power now to be transparent about what the specimens are used for, you know, what the procedures are to be able to request them, and our policy and all of those things. We had a second lawsuit consequently that was filed in October of 2010. So less than a year after the first lawsuit was dismissed. Well, not dismissed. That one was, the first one was not dismissed, it was settled. The second lawsuit alleged the same violations, but because we had that law in place and we could prove that the plaintiff's specimens had, children's specimens had not been used for anything other than screening, and that because they hadn't requested the destruction, they actually dismissed that lawsuit. So that was really great to have the protection of the law at that point. In the next legislative session, so we operate on a biennium, they actually strengthened the law, and instead of it being an opt-out, we moved to opt-in. And so now, and ever since then, we have to have written consent to retain the specimens, and that also allows them to be used in research. So at this point, for those that we receive, for all the specimens, about 72% of the forms that are returned, the parents do choose for the specimens to be retained. However, we only get about 55%, only about 55% of the specimens that we receive have a consent attached to them. So what does that mean? That means we're able to retain about 39% of the specimens that we receive in the lab for testing. So it's really important. In my mind, I mean, a few things. One, transparency and making sure that, you know, one, programs should have a policy and be transparent about the policy. I appreciate that we have coverage in statute now for the things we need to do for our daily operations. I really, really appreciate that, especially as I've seen different lawsuits in states and how that impacts them, and the ability to not just use them for research purposes, and the ability to add screens, you know, looking at rare disorders that might be coming up, but the ability to be able to do our normal screening without concern. You know, we can use them for quality control, and we can use them for quality improvement type activities. So although it was a lot of work, and at the time we thought this is, I think everyone else thought this is crazy and it costs too much, and we, you know, why do you want to spend that much money on the ability to retain the specimens? Yet I feel it protects our program to be able to retain the specimens, and it is a lot of work, and it does have a cost associated with it. Does require staff, it does require money to be able to maintain this. But we have seen an uptick in requests for the residual specimens, and we're happy to try to support research on things that have public health benefit. Did I answer your question, Natasha?
Yes, you did. And as always, you're always very gracious and in it, concerning the fact that in all of those proceedings, it wasn't just the program that was attacked, but you and your staff were attacked personally. So I just think it's really important to acknowledge that. But yes, I think that's really helpful. Would be really great to kind of hear from Tara and then Kristen about, with something like this happening, there's currently a lawsuit in Michigan, so it isn't just something that happened in the early 2000s, but is current, and programs are still facing this and under threat. Just kind of from that advocacy perspective, your thoughts and kind of what you think we should be paying attention to in this space. But go ahead, Tara.
I haven't really thought about it from that perspective. Like what Susan, gosh, that sounds like a lot that they had to deal with on those two lawsuits. I've not, the lawsuits I've seen more are around, and I'm not going to really diverge on that, go off on a different tangent, but like I've been around more with parents who live in states that don't have a particular newborn screening. And even though it's on the RUSP, states can put what they want to on their own state panels, suing states for their children's, the outcome of not getting a newborn screening test. Those have been the ones I've been, I guess more the advocacy community has talked about that I'm around more. I really can't say, I don't know enough to say about what Susan was talking about. I've just not been engaged with that. But the only lawsuits I really ever hear all coming up are from families who have not, because of the state, have not had the opportunities to have their child tested, and it ended up in a negative end for the child or the family. That's where I've heard it. So I don't want to take away from what Susan was talking about, because that's super important.
Kristen?
Yeah, I would just say that I think this really points out how important it is for advocates to collaborate with, laboratory staff, with the clinics that treat the kids with the newborn screening conditions. I think if everybody sort of has an awareness of what is happening and the pressures, like in this example, on the laboratory, and what they may need the patient community to advocate for, right, in the legislatures. I think as advocates, making sure that we, develop relationships with laboratory staff in this case, and just try to help where we can, right? Because I think the families or adult patients have a big voice, in our capitals. And so to the extent that we can make sure that we are doing everything we can to support the whole newborn screening system, I think that's a really important thing. I would say just collaborate, get to know the people in your state that work on the different pieces of newborn screening, and you can be helpful. So I'm sorry that happened in Texas. That sounds very hard. That's a challenge. And I think that making sure that we tell the story of how important those blood spot cards are. So, the greater community understands the value that they, serve in terms of quality assurance in the laboratories, or like you said, Dr. Kitzley, developing, other new diagnostic tests, or whatever it is that we need to use them for, that we communicate that out, and advocates can help speak to that.
Great, thank you. We are going to wrap up. I do want to give Susan a chance to clarify something that has come up in the chat. When you mentioned that 55% of consent come back, and of those 72% give consent to research, just to elaborate on that 55%, why only 55% come back, knowing that you are not there when they're collected, all you're doing is receiving, and just to see kind of what you've tried to figure from that, just like in a sentence or two.
So we have, we've tried to study hospitals that have better return rates and try to figure out what their practices are. I mean, what we think is happening is that it's a passive requirement that's in law. So the healthcare provider who administers the screen is required by law to give the form to them. That's the requirement. They're not, that could be in a folder with 7,000 other things. It doesn't have to be discussed. There doesn't have to be anything active in that other than the giving of the form. Sometimes we get the forms back and they're still attached to the kit, which means they didn't give the form to the parent. So we've tried to do things to collect data to try, to help us figure out which facilities are maybe still have it's still attached. We also have some where they've given the paper version that's printed off the website, like an 8.5 by 11, and the kit. And so we may get one back, but not the other. But because of how we process, it's whichever we process last. So we have 2 screens in Texas. So if somebody says no on the first screen and they say yes on the second one, then the yes applies. If they say yes on the first one and 2 weeks or anytime later say no, then we have to consider that a no, and those have to basically, depending upon the time frame, basically be pulled from the ability to retain. So if we're receiving 2 forms and one of them says no and the other one has nothing on it, but they're processed in that order, then that turns into, well, if it said yes and then nothing, that turns into a no. So we have to assume if they send it back to us and it doesn't have anything, that it's a no. So we just have, we really need to have more time to study it, more energy to study it. And we actually have a couple of research requests that we hope will help us to dive into this a little bit further. We're just looking at data.
Great, thank you so much. And thank you to all of you. As you can see, we already went over our time. We could have probably spoken for another 45 minutes on this. And I think that might be a good segue to Dylan to talk about our breakout sessions that we will have momentarily.
Yes, thank you so much, and thank you to everyone for such a wonderful session today.